Okay, hello everybody and welcome to our session. This session is called Dementia, Current and Emerging Treatments. I'll just say a few words and introduce our first speaker, Professor Sean Kennelly. So my name is Sinead Grennan. I'm CEO of Engaging Dementia. We have Kim Tully is taking over for me this week while I pursue a full-time master's in psychology. So the two of us are co-hosting this conference. And the conference is taking place over 2 days, so all day today, all day tomorrow. And then the Dementia Research Network of Ireland and the HSE National Dementia Office are co-hosting a policy and practice forum on Wednesday afternoon. So, and anyone who is active on Twitter, do feel free to join the conversation over the 2 days. Our handle is at engagingdemirl and then the hashtag DementiaConf20. So I'd first like to introduce, well, actually, sorry, before I do that, I'll just say you can submit a comment or question through Q&A or through the chat function. So do feel free during the talks to do that. So Professor Sean Kennelly will speak first and then Cathy, McHale, and then we'll have a short Q&A. So Professor Kennelly is consultant geriatrician and co-director of the Tallaght University Hospital Memory Service, and he specialises in Alzheimer's disease and brain health. And he's speaking about emerging concepts in diagnosing and treating Alzheimer's disease. So, Sean.
Good afternoon, and thank you for the opportunity to present. I'm just going to share my screen and hopefully it all. So like I was saying, thank you very much for the opportunity to present, and I'm going to go through some concepts which, depending on where people are at with regards to their familiarity to what's been happening in the world of Alzheimer's disease over the last few years, they may either be emerging or fully emerged and incorporated, and also just a little bit about some treatments that, in particular one treatment that may be, which is under review for licensing, which is the first treatment under review for licensing in almost 20 years for Alzheimer's disease. I'm going to kind of step back and do that macro view, which is what is dementia, and it's really very much an umbrella term and not a diagnosis in its own right. But regularly would be asked in the clinic, well, what do we mean by dementia? And it's really where somebody has a memory or thinking difficulty, which causes impairment in their ability to perform their daily activities. Alzheimer's disease is the most common cause of dementia. It accounts for about 70% of the cases of dementia, possibly a little bit more than that. But I also suspect as we get more into pathology-based diagnosis, we might find that there has been a slight overcall in the prevalence rate of Alzheimer's disease, because we know that there's other conditions such as stroke, Parkinson's disease, frontotemporal dementia, and other unusual causes. There's almost 100 different causes of dementia, them being the main ones. And the most common question I get asked within the memory clinic is, what's the difference between Alzheimer's disease and dementia? And of course, it's that dementia is that umbrella term that refers to that cognitive decline or that memory decline, which has resulted in functional decline, and Alzheimer's disease is the cause of it. And what does that mean? Well, it really comes down to, over the last decade in particular, and probably even over the last 5 years, we've really begun to understand that Alzheimer's disease and these other dementias, be it Parkinson's disease, Lewy body dementia, frontotemporal, they're all proteinopathies. And what I mean by that is that there are these abnormal protein variations which accumulate in the brain, which are responsible for these conditions. And in some instances, as a result of overproduction of these proteins, which then leads to toxicity and damage to certain areas of the brain. And for others, it's as a result of a loss of clearance. So the brain isn't able to wash these proteins out as well as it would have been able to do beforehand. And if and it is a simplistic analogy, but if you think of the brain then as a fuse board, you have, your frontal lobe, parietal lobe, occipital lobe, and temporal lobes, and it kind of does different things, be it as a result of, frontal lobe being responsible for many of our, working memory and personality traits, parietal lobe being very much a sensory lobe, occipital lobe for vision, and then temporal lobe is where our language centers and our memory centers are kind of based. And depending on which part of the brain that these proteins be it due to Alzheimer's disease or Lewy body or frontotemporal dementia, depending on which part of the brain is affected by this protein accumulation. The presenting symptoms of the dementia will be different. So, for example, if it's in the temporal lobes, it'll be memory loss, whereas if it's in the frontal lobes, it might be poor judgment. Whereas, you know, similarly, if it's in the frontal lobe, there might be some inappropriate behavior. And then when we kind of consider the, you know, where things are at with regards to dementia, we're probably 55,000 people living in Ireland with dementia. There's probably 500,000 people who are supporting the care of somebody who's living with dementia. And there's probably another, you know, 50 to 100,000 people who are living with mild cognitive symptoms, you know, yet undiagnosed. And what we know is that the main risk factor for dementia is increasing age, and as our population ages, the numbers of people living with dementia are going to increase. And already the annual cost of dementia is about 1.7 billion. So it's really essential that we develop better diagnostic, therapeutic and social care solutions for people who are living with dementia and the people who support their care. I thought possibly the best way to make some of the concepts a bit more tangible is to go through a case simulation. And just as they say in the movies, this might seem similar to some of the cases that people would have heard of or that may be familiar with, or indeed if there are people who have attended the memory service might be thinking, how come he's talking about me? To be clear, this is a simulated case. But it would be very reflective of what we would see in the memory service. And it's a lady who's 60 years old, right-handed, who's referred to the clinic by her GP. Generally speaking, the GPs will mention that somebody has had memory difficulties over the last few months to a year, and a brief screener, either an MMSE or, as in this case, a Montreal Cognitive Assessment will be done. And from the screening test alone, we can see early on that, you know, this lady is performing quite well, 24 out of 30, which would probably be within, you know, reasonable standards, normal standards, just a little below. And, you know, delayed recall seems to be the issue or the main issue on her screening test. With regards then how our memory services and how our you know, services for supporting people who are living with memory difficulties are set up in Tallaght, we have a centralized reception for all of these referrals. Some will go into our general geriatric medicine clinic, and they will often be people who have the primary referral would be for memory issues. They may be a little bit older and they may have clearer evidence of functional decline, in which case they will come into that general geriatric clinic and we'll try and see them quite quickly. The other stream that we have is a rapid access stream for people who may have behavioral or psychological symptoms of distress, and they would often be people that we may either see within our ambulatory care unit here in the hospital, or we may do domiciliary visits, and they would often fall into the couldn't, wouldn't or shouldn't come to hospital. And then the third stream, which I'll talk a little bit about, is then the people who come into our specialist memory service, and they would often be people who are, you know, under the age of 65, may have atypical symptoms. We would take them from on a national referral basis, and we would use the other disciplines in the memory service to do that. But regardless of where somebody accesses our memory service, the most important aspect of it, and Cathy, McHale, the advanced nurse practitioner in the service, will talk a little bit about it afterwards. The most important aspect is the post-diagnostic supports, regardless of the diagnosis disclosure. I just also said we'd mention that, you know, earlier on in the this year we started the National Intellectual Disability Memory Service along with Mary McCarran and colleagues from the Daughters of Charity. And so that's another aspect of the memory service which is developing. When people come into this third stream, which is, you know, it's a 5-day multidisciplinary service, people will have, you know, a detailed neuropsychological assessment. Because we grew out of, I suppose, a gerontological service, we also very much look at things like nutrition, we look at gait and frailty, and we look at their functional performance. So our occupational therapists will do an assessment of motor processing skills, and where there's any language issues, our speech and language therapists will be looking very much at cognitive linguistics. And the process is that the advanced nurse practitioners will do the standardized format or battery, a scan will be booked. This is the key element, which is why I've highlighted it, is the multidisciplinary team, a consensus diagnosis, where we all sit around as a team and discuss the neuroimaging and the neuropsychological profile and the history that has been garnered earlier on, and then decide whether or not further assessments or neuroimaging is required, and schedule the disclosure appointment with the physician. So this lady then came into that stream. Her medical background was that she had a history of asthma, was only on inhalers, had minimal alcohol intake, had a family history of Alzheimer's disease in her late 60s. Her mother, who developed it in her late 60s, who passed away, unfortunately, by the age of 72. So effectively, she had short-term memory problems for the last 6 months to a year, recurring kind of amnestic, which means memory symptoms, forgetful of names, forgetful of shopping. And the main thing, and there's nearly always one thing that prompts somebody to come forward into the clinic to get a review, was she almost forgot to collect her grandchild from school one day, and that had really scared her. And as a result of that, and in the context of the family history, she really got jolted and wanted to see, because she would have been a very organized individual. She's still working, runs her own business, was managing the accounts and staff, but maybe noticed that it was taking a little bit more effort and she was more tired in the evening times than she was before. The informant from history was from her husband, and immediately what I'd say is an informant history that comes from a wife is always far more detailed than the informant history you get from a husband. However, he did confirm that she had short-term memory issues, was quite repetitive in conversations, but was adamant that there was no functional loss or decline. Her physical and neurological examinations were normal, and the routine blood tests that we would do, including things like testing for glucose and folate, B12, thyroid function tests, were all within normal ranges. On her neuropsychological profile, then we could see that, and this is a test called the repeatable battery for the assessment of neuropsychological status, or ORBANS, is quite well known now. You can see it breaks down several tests into the domains of immediate memory, visuospatial memory, language, attention, and delayed memory. And we know where the 50th centile is, so we do this relative to people's education and relative to their age. So in other words, we're comparing like with like always. And you can see where the 50th centile is. And while she performs better than that for some domains, we can see for delayed recall, she's more than one standard deviation below. So there's certainly some evidence supporting her own subjective evidence. There's now objective evidence that her memory performance isn't as good. But when we look at the other scales, so there was no evidence of anxiety or depression, no evidence of delirium. Her executive function tests were quite good. Her gait assessment was good. Nutritional status was fine, and her vision and hearing were also fine. The next step in the process would always then be to do neuroimaging, and we would do neuroimaging on pretty much everybody who comes through all of these streams, regardless of whether somebody is presenting with more advanced symptoms than another. Once they were able to tolerate it, at the very least, we would always be trying to do a CT brain to evaluate somebody's to make sure that they don't have any strokes or tumors or anything like that, and in particular that might be causing the memory difficulties. It's not so much that there's any scan that's indicative of Alzheimer's disease, but you want to make sure that there's nothing else that might be causing the symptoms. This lady's MRI scan was largely unremarkable. She's a small little bit of stroke disease. A small bit of these black areas is the fluid around the brain. These gray areas is the brain tissue. And in this sequence, basically the fluid has been darkened out so that you're able to see the tissue clearly. In a younger person's normal brain, there will be no evidence. You won't be able to see any black here. So there's a little bit of shrinkage in the brain, and that happens as we get a little bit older. This is probably more than you would expect for somebody who's only 60. Okay, so that's what cortical atrophy means. So there's a little bit of shrinkage. And in this area of the brain, in particular, this is where our medial temporal lobes are, and this is where our hippocampus, which is responsible for memory. There's a little bit more shrinkage in that area than we would expect to see. But all in all, it's a largely unremarkable brain scan, and nothing that you would say was terribly, that there was anything terribly alarming on it. So her working clinical diagnosis at this stage is one of what we'd call amnestic mild cognitive impairment, and I'll talk a little bit about what that means later on. In the last 4 or 5 years, so we started doing them here in Tallaght in about late 2016. There has been the ability to do cerebrospinal fluid. So that's where we do a lumbar puncture, which is a little needle into the lower back with a local anesthetic. And we've been able to do measures of proteins that we know are associated with Alzheimer's disease. in the CSF, which is the fluid, if you like, that bathes the brain. And as you know, up until a couple of years ago, and we'll talk about it, we had no real objective way of knowing whether my suspicion that somebody has Alzheimer's disease or not was correct, unless we did an autopsy after they had passed away and examined their brain for these proteins that we know are associated with it. The key proteins are amyloid and tau, and we'll talk a little bit more about them as we progress. But if we look at this lady's lumbar puncture, we can see that the protein amyloid is reduced, and her total tau and phosphorylated tau are elevated. And this would be consistent with a statement, if you like, that Alzheimer's disease pathology was detected. So this is a lady who has subjective symptoms in that she's noticed her memory not as good for the last 6 months to a year. We've got objective evidence that that's in fact what's going on in her neuropsychological testing, because her memory scores are lower than other people her age who were educated to the same extent that she was. And now we have the other objective measure where we now know that this pathology that we know is associated with Alzheimer's disease is within her brain. And when you put all of that together, she still has mild cognitive impairment, and that, if you remember back, the definition of dementia is where you have functional decline. So even though we talk about memory a lot, it's actually function that's the most important aspect of diagnosing dementia. So she doesn't have dementia, but she does have mild cognitive impairment. And there is an elevated risk. So it's not definitive, but she has an elevated risk of converting from mild cognitive impairment to a more advanced memory difficulty, such as dementia, over the next 5 years. So this is somebody that we would really like to kind of work on reducing that risk and having a focus on risk reduction. And her refined diagnosis is amnestic mild cognitive impairment due to Alzheimer's disease, or some people would call this prodromal Alzheimer's disease. So the first concept I really want to talk about is this, because it is quite a new concept, that as well as looking at the clinical picture, we start looking at the pathology. And that what pathology is the disease process going on within the brain that results in a diagnosis of Alzheimer's disease. And if we look at the history of Alzheimer's disease, well, Alois Alzheimer's described it initially in 1906, and really for the guts of 100 years, there was very, very little. Certainly for 75 years, there was very little research into what he had identified, and it's in particular since the 90s. So over the last 30 years that we have increased our understanding on the pathology, so the disease process which results in Alzheimer's disease and the treatment that goes into that. But I think the key thing is that we need to bear in mind that there hasn't been a drug license for the treatment of Alzheimer's disease since 2001. And when you consider the numbers and the impact of something like dementia and Alzheimer's disease and how common it is, compared to, let's say, another condition like cancer, where we have on average 25 to 30 new chemotherapies per year in cancer, the fact that we haven't had a single agent since 2001, when memantine was licensed, really gives you an indication of how complex this condition is to treat, and the level of urgency that there is for us to identify new treatments. Alois Alzheimer's disease, and this is August Dieter, who was the young patient that Alzheimer's used to describe these proteins of amyloid and tau in 1906. Along with his colleague Emil Kraepelin, who worked with them in the lab. And it's incredible how accurate their description was about these amyloid plaques and these neurofibrillary tangles of this protein tau, and how they were responsible. And of course, what's happened over the last few years is we've been able to evolve that understanding to understand, that knowledge that amyloid is the key protein involved in Alzheimer's disease. Tau is then the secondary important protein that is responsible for an awful lot of the cognitive decline. But there are these other factors, such as lifestyle events, vascular risk factors, inflammation within the brain, and then genetic risk factors. And we'll touch on some of them as we go along. Some people may have heard of this theory called the amyloid cascade hypothesis, and sometimes it's called the tap and the sink theory. And essentially, it really, since the mid-90s, we've known that amyloid is probably the key protein involved in Alzheimer's disease, and that it's not that it's the one that does all the damage, but it is probably the snowball off the top of the mountain. It's the one that triggers a huge amount of damage. for people who have a genetic predisposition, and it's worth mentioning that only 2% or so of Alzheimer's disease is due to gene mutations which cause an increased production of this protein. The vast majority of Alzheimer's disease, even in the context where there might be a first-degree relative, is what we would call sporadic Alzheimer's disease. In the familial form, it's that there is genes which increase the production of this protein beyond the ability of the brain to clear it. And in the sporadic form, or in the, if you like, the one that happens, the later onset Alzheimer's disease, it's really where the clearance mechanisms for cleaning out this protein from the brain don't work as well as they would have. But either way, regardless of, once this protein is there, it kind of it goes into a pathway which basically then progresses until you end up with damage to the nerves within the brain. And of course, there's an interplay between inflammation and stroke events as they go along. One of our other key understandings over the last decade or so was that there was a difference. So when we identified amyloid, our main focus was on these plaques of amyloid. And actually what it's turned out is that these are relatively inert and don't cause, so while there's big clumps of the protein, they're relatively harmless, in that, yes, they're there, but they don't cause much damage. The main types of amyloid that are most dangerous are the soluble types and the smaller types of amyloid. So even our ability to understand differences in this protein have refined over the last number of years. And this is important because some of our earlier treatments that were anti-amyloid were probably targeting some of these inert or inactive forms of amyloid, which meant that they were never really going to show the benefits that we would have expected to see in some of those trials. But ultimately, this amyloid then hits off this protein tau, which accumulates often as we get older. And it's those kind of cycles then that happen, that are upregulated by amyloid, that cause the neurodegeneration. And neurodegeneration is the term we use for the breakdown in cells within the brain. Ultimately, the amyloid cascade, because of the treatments haven't worked, there is still some controversy about whether or not amyloid is the key target. But what most people agree on is that as we grow older, we have this protein tau that accumulates in our brain. It's kind of a wear and tear protein that accumulates. And some people also accumulate amyloid. And in those people who accumulate amyloid, often the amyloid twists the tau, if you like. It causes the tau protein to become even more deranged, or what we call misfolded. And that prompts, if you like, this response, which then causes these brain cells to die. And that other things such as vascular, so blood vessel disease and other factors can interfere with that process and accelerate it. And that's generally what most people would probably, as opposed to just a cascade, which is a sequence, most people think that it's more integrated. So there's to and fro between amyloid and tau as part of this pathway. So if we lift back to where we were at before this knowledge, well, for the guts of 25 or 30 years, we were recruiting people into studies, and it was really on the basis that a diagnostic criteria that said that if you had memory difficulty and you were between the ages of 40 or 90 and you were still able to talk, and I wasn't able to think of any other reason as to why you might have a memory difficulty, that probably meant that you had Alzheimer's disease. And it was very much based on Alzheimer's disease as a clinical syndrome. Now, while that might seem reasonable in some contexts, it is the same as me saying that if somebody has put on weight and is more tired, then they probably have hypothyroidism. So if you like, without doing any blood tests to check their thyroid function. So if you like, there was no objective marker on that diagnosis. And when we looked at those early trials, which had looked at medicines to reduce this protein amyloid, as those early trials were finishing, we developed the capability of measuring this protein within the brain. And what we found that over a third of people who were enlisted or enrolled into those trials, which would have come from expert centers. So they would have been recruited from centers that would have been participating in these large studies. A third of them had no Alzheimer's pathology. So in other words, the criteria in these expert centers of trying to diagnose amyloid and Alzheimer's disease by pathology. A third of them didn't have any, and there was no way these medicines, of course, these medicines as anti-amyloid agents couldn't work because there was no amyloid there. So increasingly the term now Alzheimer's disease, it represents a pathological process where the symptoms are kind of part of the disease continuum. And the Alzheimer's Association and the National Institute of Aging kind of came out with criteria in 2011 to reflect this. And really we have the key ones are to talk about preclinical Alzheimer's disease. And these are really your prevention studies whereby there's no cognitive symptoms, but they might have some of these biomarkers. And you're only really ever seeing those in a research context. They're not the people who are presenting into the memory service. Prodromal Alzheimer's disease is like that, the case of that lady that I presented, who have they've mild neuropsychological deficits. They're still functionally independent, but their biomarkers are positive and suggest that they have Alzheimer's disease as causing that. And then dementia due to Alzheimer's disease is what would have traditionally and still does come into clinic quite a bit, where people have functional impairment and likely have Alzheimer's disease. I kind of just put this in as a reference, but as things evolved, they looked, the National Institute of Aging in 2018, really for participants in clinical research studies now have this ATN classification, which looks at, amyloid and tau and neurodegenerative markers from the point of view of participating in these trials. And I suppose you've got to ask is if we say these are the criteria that somebody needs to have to participate in a study, well then obviously this should be the diagnostic rigor that we're looking for from clinicians for people to be able to make a sound diagnosis of Alzheimer's disease. So when we take the predictive markers and we put them all together, well, how far in advance is it that we're able to look at? Well, the actual thing is if we take that lady's CSF biomarkers, well, so up to 25 years in advance of her having any symptoms of cognitive decline, those markers will be deranged and will highlight her risk. And similarly, we'll go through some of so where we saw that shrinking on the MRI scan, that can maybe be up to 15 years. Whereas if you take the neuropsych testing, it's really often within 5 years. So you can see these objective biomarkers are far more predictive than neurocognitive testing or neuropsych testing. And this gives us a big window potentially to intervene. We know that when we apply these criteria into the clinical setting, that it does give better diagnostic accuracy, and that people with these biomarkers are more likely to progress to developing Alzheimer's disease, dementia, or functional symptoms than people who don't have these biomarkers. And in the NICE guidelines, which are the National Institute for Health and Care Excellence guidelines over in the UK, biomarkers have been brought in 2018 when they brought out their clinical criteria for their model of care. They have incorporated biomarkers as no longer just part of ID research, but they've highlighted the need for biomarkers to be integrated into a formal Alzheimer's disease diagnosis. So with regards to the CSF studies, I mean, as I said, it's a lumbar puncture. So Brian Lawler several years ago led a consortium within an Irish context to come up with a guidelines around who should have them and how they should be performed. And I've put a link down to that. That was the InBind consortium, and they're all processed within they sent the pathology or the immunology laboratory in St. James's, and we look for amyloid, phosphorylated tau, and total tau. And most studies now have demonstrated that if you look at the combination, so as opposed to taking one of those proteins in isolation, but if you look at the combination of how those proteins, the sequence of those proteins being affected, there's a sensitivity of almost 100% and a specificity of almost 90% for identifying Alzheimer's disease versus healthy controls. Who do we do biomarkers on? Well, here in the memory service, everybody under the age of 80, but there are some exceptions to that. We generally wouldn't do them over the age of 80 just because as people get older, they will have coincidental Alzheimer's pathology anyway. All people who have mild cognitive impairment, we would often offer them to. People with mild dementia who wish to know for sure what is it that's causing their mild dementia, we would do biomarkers on. Where there's an atypical presentation, we will often do biomarkers, but while the sensitivity is still pretty good in that context, the specificity, because you can often get Alzheimer's disease co-occurring on those proteins co-occurring with other proteins that might cause other causes of dementia. So interpretation needs to be a bit more cautious in that setting. But we would also do it in people who have subjective memory complaints, who wish to know whether or not, some people will have a significant family history. Some people will be, have a very high premorbid baseline and be high performers, and want to know what is their, whether or not they have Alzheimer's disease because they subjectively have noticed their own memory not being as good. We'll generally avoid it in people who have established or advanced dementia symptoms. We won't do it in people who are on anticoagulation, just because as a result of the blood thinning, it can make it a little bit more complex. And we won't do it where there is a, where it could be a procedurally complex symptom. So where somebody might have had a spinal fusion or something along those lines. This really was just a brief, Deirdre McCartan, when she was working with us a few years ago, had a look over the early CSF samples that we had looked at within the memory service. And it was about 65 to 70% of patients where, it's indicated proceed to CSF collection. So understandably, some patients would say they'd rather not have a lumbar puncture, and that's absolutely fine. Some people would have those other exclusion criteria, and that's why we wouldn't do it. But by and large, of the people that we think would be eligible, 65 to 70% are able to have a lumbar puncture to look at this. And the majority of the lumbar punctures that we do, we identify, Alzheimer's disease as the main factor underlying their memory difficulties. And then there is these non-Alzheimer's disease pathologies, that would be in about 15% of cases. And this kind of just brings it back into that classification that we talked about, where we're looking at merging that clinical picture along with the biomarkers. And what we see is that, in people with mild cognitive impairment specifically, many of them have MCI due to Alzheimer's disease, and 65% or so. So PET scanning and PET imaging is one of those other modalities that has really increased in use over the last few years. Now, it isn't as accessible as being able to do lumbar punctures from the point of view of our services. There's only about 5 or 6 PET scanner machines within the country, and most of them are used for oncology and for cancer. But we've always known that this is what's called an FDG PET, which basically it radio labels glucose, and we can look at activity of areas within the brain. And by determining which areas of the brain are less active than other areas, where the proteins might be. So it's kind of an indicator of neuronal injury. It can be quite expensive to do, in that they're over €1,500 generally, and there's limited availability from doing them. So FDG PETs were a modality that was available, but not frequently used. We would maybe do 15 to 20 or so a year, but what's happened over the last few years is there's been a development of what's called amyloid PET imaging. And what amyloid PET imaging is if you take this, so these are 2 subjects who came through a recent clinical trial here with us. Both have amnestic mild cognitive impairment, same as that lady would have done. But what we're able to do is stick on a tracer to identify the amyloid within her brain. And that tracer then highlights the level of protein within the brain. And if you look here, there's 2 people who have the exact same neuropsychological profile, but by doing this amyloid PET image, we're able to see which one of them has a high amyloid burden. And the importance for this is, yes, with regard diagnosis, it's important because it probably confirms this person is far more likely to have an Alzheimer's disease process going on, but also from the point of view of identifying whom is most likely to benefit from an anti-amyloid treatment. Tau PET imaging is similar. It's a radioactive label whereby we stick it onto that protein tau, and we're able to image the areas of tau in the brain. It's mainly a research modality at the moment, in that it's less stable of a compound than most of the amyloid imaging tracers, which are now used quite widely in clinical context. And the benefit, or the potential benefit, of tau is we may be able to distinguish better between Alzheimer's disease and other causes of dementia. And that may be the real benefit that we see with tau, but almost certainly it will be when it's done in combination with amyloid PET scan. We still use MRI scans. I talked about this lady's medial temporal lobe, and that's a good indicator. That's a good radiological indicator of neuronal injury that we can see in people with Alzheimer's disease. And we also use the MRI scans. Of course, we get the added benefit of being able to look at the shrinkage within the brain, and also whether or not there is vascular disease or blood vessel disease. So it has those added benefits. In the last few months, there's been lots of publicity about the rapidly evolving potential for blood tests, and we know that there is from the University of Lund in Sweden, the development of quite a stable and predictive blood test. It's still very much at research areas. It measures a form of phosphorylated tau, or p-tau 217, which is slightly different to the p-tau that we look at in the CSFs, but in several papers that have been published on it, it performs very similar to the accuracy of cerebral spinal fluid and the amyloid PET imaging, and it looks like it has a 20-year predictive window. So, a blood-based biomarker that is that predictive will be a real game changer for us having a certainty around the diagnosis of Alzheimer's disease, and how we incorporate that into our diagnostic pathways is going to be very, very important. I mean, there is lots of pros and cons, and people will be able to come back and, as to this biological based model, on the pro side, it's very much, it gives a tangible focus for diagnosis. And I think it's quite reassuring for most of the people that I would look after, for them to know exactly what's causing it. Against that, some people say it's a bit reductionist and that we're really binary about it's either, Alzheimer's disease or it's not. And some people would also question correctly whether the amyloid hypothesis will still be true. But, from the point of view of people who maybe question it about the dangers of an early diagnosis, I think it's a debate that's past, in that, the people who are coming to memory services want an accurate diagnosis. And this is really borne out by this survey in 2014 of 10,000 participants, whereby, over almost 3/4 said they wanted to know what kind of neurological disorder they had if they had no cure, and 80% said they'd want to know what their relatives had if they even if they didn't have a cure. 90% said they felt it was very or fairly important to have access to an accurate diagnosis, even if it was incurable. And then we know 83% would want access to a diagnosis in the context of dementia. So people themselves have actually said that they want it, and nobody is advocating using these modalities as screening. It's really just about increasing the accuracy and diagnosis of people who are attending our clinical services. And timely diagnosis is very important for people, and most importantly, it's because we're able to, incorporate them and bring them into the post-diagnostic support services, which Cathy will talk about in a few moments. And the other caveat is the age-adjusted lifetime risk of dementia is declining. So if you look at this Framingham cohort in the US, which has been going on for several decades, we know that the age-adjusted incidence of Alzheimer's disease, or dementia in particular, has reduced about 40% over the last 40 years. And similar is evident in longitudinal dementia registers in the United Kingdom, Sweden, Netherlands, and Germany. So the age adjusted, so overall numbers of people living with dementia is going up because we have far more numbers of people who are living into later life. But the overall age-adjusted lifetime risk is declining. And when we've got to look at why is that, well, that's because actually the second concept I'm going to briefly talk about is that we now know dementia is preventable. And it would have been heresy to suggest such a thing maybe 10 or 15 years ago. This is from Jill Livingston's publication in The Lancet, which looks at those modifiable risk factors that, if we work on those, up to 40% of cases of dementia may be prevented. 9 were published back in 2017 when Jill and colleagues did their first Lancet Commission report, and they've added on 3 more this year, which include head injury, excess alcohol, and air pollution. And Cathy will talk about how we try and take that approach. So if you take that lady's case, really what you want to be doing is looking at these modifiable risk factors. You've identified that she has a heightened risk, so you really want to be getting into a risk reduction space with that lady. And Cathy will talk about the Brain Health Clinic and how that looks like and how that targets some of those factors. And we've known for a long time that this concept of cognitive reserve, whereby 30% of older people who have a lot of Alzheimer's pathology in the brain don't have dementia, so that there is these other protective factors that have, one person develop dementia at a much lower threshold of disease burden than others would have it. And when we look at those brain health and the determinants of success, central to it all is exercise. And exercise is able to work on increasing brain cognitive reserve, reducing the damage, and reducing the inflammation. So it's a very, very important aspect. when we talk about emerging treatments, well, our problem has been that we haven't left it to the Daily Express often enough to cure Alzheimer's disease. If we'd listened to them, they've beaten Alzheimer's disease and cured it several times over the last few years. And of course, most of these, including chocolate, haven't actually been able to stand up to scrutiny. But there have been some studies, and when we look at treatment, we have to look at it a little bit sideways. It's not all about amyloid treatment. The SPRINT MIND study was a study that looked at intensive reduction of blood pressure versus standard reduction of blood pressure in midlife in particular. And what they found is that there was definitely a potential to reduce the risk of people developing mild cognitive impairment or a composite of mild cognitive impairment and or dementia over the subsequent follow-up for 5 years. So aggressive blood pressure management in midlife translated into a reduction in the development of dementia. So blood pressure therapies are a preventative therapy for developing Alzheimer's disease. And this is how we have to look at it when we're taking on the concept of brain health. Similarly, the FINGER study, which was a Finnish gerontological intervention study looking at a multimodal intervention, exercise, diet, and cognitive training, over 2 years demonstrated, a big impact, profound impact on a benefit on cognition. And, very few people dropped out. So it was a very well tolerated study, but we need to develop more feasible, forms of that. And of course, there is what's called now the worldwide FINGERs, which is looking at several of these multimodal lifestyle intervention studies in midlife as a means of preventing dementia. Medications, unfortunately, have been less optimistic, and it's this slide I often throw up labels, and we've had many horses and riders that have fallen over, and none more so. I mean, 2019 and 2020 have been really significant and quite devastating from the point of view of drug production for Alzheimer's disease. Other than this one agent, out of the darkness, one agent has kind of come true, and it's aducanumab, which is Biogen, I say, and essentially it's an anti-amyloid agent. It binds to amyloid, and it clears amyloid from the brain. Early papers had identified that it was very, very effective. It was into phase 3 studies. It's a monthly infusion, and side effect profile seemed pretty good. And everything looked like it was going well. The last time I presented this, we were talking about phase 3 studies, which are those advanced studies, and it all looked very positive. And then all of a sudden, in March 2019, Biogen discontinued the study and said actually they'd done their own interim analysis and it looked like it was going to be negative. And it really shocked, because out of all of the agents that were coming through, it had been the most promising one. And it was very disheartening to investigators to see that this really brought into question as to whether the amyloid hypothesis was ever going to work out. But then a few months later, they went and did their analysis, and they found that there was significant signals from the point of view of clearing amyloid and benefit treatment that they had failed to see when they had done their interim analysis. And as a result of that, actually they claimed the trial was, instead of it being discontinued, that in fact it actually was a success. So they restarted the study, and they have filed to the FDA, so that's the drug administrator over in the UK, for licensing. This would be a big, a big event from the point of view of the Alzheimer's disease world. I mean, I'm also a stroke physician, and I saw firsthand the impact that thrombolysis made, not just on the direct treatment of stroke, but actually on the development of stroke units and the subsequent development of stroke care beyond it. One of the key things that Alzheimer's disease and dementia in particular has lacked has been a key treatment by which we could grow those other necessary services. So even if it's only a small number of people who maybe are eligible for this trial or for this treatment, it still may be the stimulus we need to get other treatments up and running, and those other care pathways that we know, the post-diagnostic care pathways that are really important up and running. And the date that's marked in on my calendar is March 2021, where we'll know the FDA's decision, and the European Medicines Agency is likely to follow that decision, and support it whichever way they go. The potential that we might have a new treatment after 20 years without one and for Alzheimer's disease is something to be optimistic about. The overall political societal commitment to finding cures and treatments for Alzheimer's disease is heartening, albeit it's a very complex condition. And I hope I've been, relatively clear in demonstrating just how complex it is. We have a much better understanding of the life course and the risk factors that develop over the life course. Blood biomarkers are going to be a game changer from the point of view of diagnostic accuracy, as will things like tau PET imaging. And I haven't even mentioned the potential tau immunotherapies that may be emerging. So there is this pipeline of potential treatments, but we can be cautiously optimistic. So even though we've had a few years of failed trial after failed trial, we're hopefully beginning to see that there may be more interventions coming out. We do some of these disease modifying trials here in Tallaght, as they do in some other hospitals around Ireland, but we need to ensure that there's an equitable access for Irish people with memory problems into these studies, as there is for cancer, or people who are living with cancer to get into cancer trials. We need to similarly make sure that people who are living with dementia and Alzheimer's disease in Ireland are able to access these trials. And we have to start thinking in terms of Alzheimer's disease prevention and the importance of a healthy heart equaling a healthy brain. So thank you very much.
Thank you so much, Sean, for such an interesting, informative talk. I think what I might hand over to Cathy and then have questions at the end, because some questions have been coming in through here. So thank you so much. So if we have Cathy here, Cathy is an advanced nurse practitioner in the Memory Assessment and Support Service at Tallaght University Hospital and is a colleague of Sean's. So Cathy, I will turn on your video here. Hi, Sean. I might just ask you a couple of questions while we're waiting for Cathy to tune back in there. I mean, gosh, so much has been happening over the past number of years. I mean, you were saying there wasn't a new treatment since 2001, and now there are some effectively in the pipeline. Could you talk a little bit more about that? You commented on the immunotherapy that might be an option, but you didn't go into it in the tau immunotherapy.
So the tau immunotherapies are very much at an early stage. I mean, so what we understand from the process in Alzheimer's disease is that if we look at amyloid itself, doesn't predict cognitive decline very accurately at all, but tau does. So as we accumulate more tau in the brain, actually that's what really, if you like, symmetrically plots out the decline in cognition. So tau is a far better correlate of declining memory. So it's always kind of been one of those things is that while we're chasing after amyloid, we know that happens upstream rather than what's happening, if you like, in real time, which is the tau accumulation, and that's what's resulting in those nerve cells dying. So tau immunotherapies are very much at a kind of experimental stage. I think aducanumab, the amyloid therapy, the amyloid immunotherapy that's coming through, that's the one that I think is certainly the it's exciting and interesting, and you would be cautious about it. Like I said, it's had an unusual kind of sequence whereby everything looked like it was going very well. People were very hopeful, and then all of a sudden they shut down their phase 3 studies, and then they came back out and they said, well, actually, sorry, we jumped the gun. When we looked at the data, it turns out the higher doses were positive. And actually, so the way that study was structured is they had 4 dosing levels, and they didn't see much effect at the lower dosing levels, but at the higher dosing levels from 2 different studies, when they pushed those together, actually they saw that there was an effect at the higher dosing levels without any significant side effects. And it's long-term being a criticism of many of these studies is that we tend to go in at too low a dose. And part of the reason for that was some of the earlier studies that we were doing 20 years ago, looking at the original immunotherapies, caused some significant side effects, in particular a thing called meningoencephalitis, whereby people got this big inflammation in the brain. And it's made people be very cautious about going too aggressive with any of these therapies. But we're looking at compounds that, because we have this thing called the blood-brain barrier, it blocks an awful lot of these agents getting into the brain. So in some of these trials, we know that only 1 to 2% of what we're putting into somebody's peripheral system is actually getting into the brain. So as a result, we're probably underdosing for the effect that we're trying to get. And that's been one of the, that's been a constant, if you like, discussion point when we're looking at these therapies. So there's lots of potential reasons as to why many of these trials that have been very, very expensive to perform haven't worked to date. But you know, it's nice to know that there's one that's at least gone to the next stage, which is seeking FDA approval. And it'll be very interesting to see what the FDA think on it, because like I said, I think it has had an unusual course to seeking approval.
Okay, and you gave a date there of March 2021 that you'd be expecting the FDA decision. So you commented about Europe. I mean, what would happen? Let's say the FDA gives it the green light. What would happen then? And in terms of time frame and process?
So, yeah, I mean, so really good question. I suspect actually the pressure, just by virtue of the fact that we don't have therapies, I think there will be quite a bit of pressure for the European Medicines Agency to look at this and probably to replicate. I'd be surprised if they came out with a different. It's just that it would be unusual anyway that they would have an alternative or a different ruling. I would expect that that would happen fairly quickly. It's, you know, there's generally a reciprocal kind of piece with that. And the actual thing, though, the last part of your question is what's most important. We have very, very few centers that have integrated biomarkers. There's no way that you could be giving these therapies without biomarkers. So that's why the pathology-based diagnosis becomes so important. You would need to be identifying those people who definitely have amyloid in their brain for us to trial them. And to be identifying people at a sufficiently probably mild level of symptoms that they're likely to get that sustained benefit from trialing those therapies. And I think it would probably take up to 2 years before we would have that ingrained into our services. And I think that's why in 2016, as a result of doing these trials, that's why we looked at kind of trying to incorporate it, because we got a first-hand view as to what the world would look like should one of these therapies arise. And what we didn't want to be doing is trying to search around and establish this, you know, in the context of a lot of pressure to deliver therapy to people. And that's why we looked at incorporating it into the general clinical practice. But I think the big challenge will be, at the moment, we don't have enough centers who do pathology-based diagnosis.
Okay. And the CSF biomarkers and the different, you know, advances in neuroimaging that you commented on there, looking nationally in Ireland, is that available throughout Ireland? I know in Tallaght University Hospital, obviously it is.
So from the point of view of, as part of Brian's work previously in Inbind, you know, we developed the immunology lab in James's as the national centre. And actually that was a key thing, because different laboratories could have had different thresholds right around the country. So to pick one laboratory to say, right, this is going to be the national laboratory, we're going to send all of our samples. That was a key thing. So anybody from any hospital in the country can do a CSF test for these CSF biomarkers and send it to James's. Now, is there a capability for doing lumbar punctures and an accessibility for doing lumbar punctures? Well, that depends on the services. As geriatricians and neurologists, we would, you know, they would often do, we would often do biomarkers. But then, let's say psychiatry-led services, it may be a little bit more difficult for them to get CSF. From the point of view of amyloid PET, so amyloid PET is going to be clinically available in Ireland from January this year. And we've done studies previously, research studies, where we've used amyloid PET and we've had to fly in the tracer. But from January 21, there will be the ability for people to have amyloid PET, and amyloid, that the compound will be produced in Ireland. But at the moment, we don't know how it's going to be, you know, how accessible that's going to be and what's the price point going to be for it. But it will be possible to have it done in Ireland from a clinical point of view.
So thank you so much it's great to be part of this conversation. The post-diagnostic piece is one of the most integral pieces, really. And so as Sean has laid out the evidence there, we know the importance of trying to turn back the dial and trying to focus on brain health. And we have known this probably from the very start. I don't know if you can go into the second slide there. Great. So I suppose our service has been up and running since 2014, and when we began, even though we were very aware of trying to turn back that dial and trying to, you know, empower patients to appreciate what they could do to improve their own brain health, what we did from the start, I suppose, was try to initially focus on our assessment battery and on doing a very good job of the diagnostic piece. But as we've evolved over time, we are now, I suppose, better able to focus on trying to infuse brain health into everything that we do. So I suppose I'm going to start and talk a little bit about brain health and how we've tried to operationalize the things that Sean has laid out, and then sort of flow into post-diagnostic support and how we think about that. So I suppose at this stage of our business, brain health isn't superfluous anymore. It is something that we would take very seriously. So within a few weeks of diagnosis, we would bring patients with subjective memory complaints, MCI and mild AD back into our brain health clinic, which is myself and Joshi Juki, my fellow AMP. We would spend about an hour with that patient, and we would try to give them a personalized plan around their own brain health. And as Sean has said, you know, we have a lot of evidence, but the weighting of the components is not altogether easy to operationalize, if you know what I mean. So what we've decided really is to take a more interventional focus when it comes to managing vascular risks, and to make it a personal picture for the patient so that they can see the things that they might be able to tweak or have an impact upon. So as the evidence evolves, we're going to just try to apply, you know, the hypotheticals in a practical way in order to instill that information across to them. You can move along into the next one if you don't mind. Yeah, so I mean, as Sean has said, when we started to create a battery and create this piece, it was difficult enough at the start because it really doesn't exist worldwide. There are little pieces of it that are being done very well, but in general, as the evidence evolves, we didn't really have anything to take from. So it was about creating a piece that would honour the knowledge that we have around midlife modifiable factors and late life, and try and put them together, try and sort of sit them alongside the WHO guidelines, and try to create a battery that would instill a brain health sort of mantra into our clinic. You can move forward into the next one now. Thank you so much. So what do we do? Applying the evidence. Again, as I said, trying to be broad, trying to incorporate everything that we felt might be important. Quality of life, we would measure that. We would have gotten to know our patients very well, and I'll talk about our pathway in a minute. But, you know, just focusing on the social piece, alcohol intake, smoking, and you know, signposting patients to supports, and just seeing where they're at really, and trying to empower them to understand that they can make changes that will make them live better. We would think that sleep is a very important aspect when it comes to dementia, and so we would talk to patients, we would measure their sleep quality, and we would have an imprint of it from their family's point of view as well. And we would look for those sleep disorders that we would regularly see, and then we would do a piece around how they can promote sleep hygiene, from the simplest measures to the complex. And so I suppose a huge part of this, and Sean has talked about it in depthly really, is the vascular risk factor modification. So again, you know, we would do all the measurement piece. We would talk to patients around blood pressure management, cholesterol control, diabetic control, and all of the factors you see listed there. And so, you know, this is something that we've developed over time. We have access to blood pressure monitors, and so really trying to drill into that piece from a personalized point of view. Optimizing sensory issues, extremely important, and we've seen it in the Lancet, the importance of hearing. And very early, actually, just after that piece of work came out, we linked a pathway into an audiologist. It's something that we would focus on at the time of first assessment, making sure people are compliant with their hearing aids, and just informing them of how important that is. We look to vision as well, so signposting patients around that piece, and just, I suppose, explaining to them how important that can be for prevention of delirium, which is something that we would inform our patients of as well. So you can move through into the next one, if that's okay. Great. So mood comes hand in hand. A lot of our patients would have issues with anxiety and depression. So we would measure that. We would, we get a very good feel for where our patients are emotionally, psychologically when we meet them first, because we spend quite a lot of time with them and their families. So it's really signposting to, you know, counselling options and through primary care, and just monitoring that piece over time. Exercise is fundamental, and I know Sean has talked about the finger study. It is, better than any pill, and it's something that we would talk to our patients about from the very start. So we would measure people's activity. We would then signpost them to medical exercise programs such as XWell or Seal Blue, to exercises they can do at home. And again, it is really about bringing them into that space where they can actually feel that something is attainable, not making them feel bad about how little they do, but like small steps. And again, when I talked about the weighting of components, most of our patients that have gone through XWell have really benefited from the social interaction. Their mood is improved, so there's definitely an interaction between those components that makes people live better. Falls and frailty, so we're grounded in gerontology really. Joshie and I would both be from that background, so we would look at the person from all of those aspects as well. Frailty scales and diet, again, extremely important, measuring it, but also then Mediterranean diet score. We sit with patients, we go through every element, we give them recipes, but also, there are issues such as food security, signposting patients to public health nurses, Meals on Wheels, really trying to make it as comprehensive as possible. The social connectedness piece, we would see as being crucial really in terms of mood particularly, but just signposting people to groups, to culture, to the cultural quarter, which is on our doorstep, which I think a lot of our patients don't feel they can be part of that world, but we do try to make them feel they can. And it really is just about increasing confidence, getting people out, and just reinvigorating them, I think. So happy to move along there. So I just wanted a snapshot of the service, just to sort of get a feel of how we sit and where we are. So ambulatory care pathway, we have, as I said at the start, evolved over time. And on one side of the left side, we're really talking up in the corner about community. And that is always our goal. Let's get all of the care and the interventions as close to the person's house as possible. And let's make those community supports something that we are aware of, that they know what we're doing and we know what they are doing. And I think there is a big focus on integration of care. In the early days, before the integrated care team became a reality, we may not have been able to do this so well, but now we really are able to support patients a lot better on the pathway from the start to finish of their journey, really. So we would, have a bi-directional flow between the stroke service, the fall service, the JEDI service, the general medical clinic, and then flowing into acute and rehab. So patients, wherever they come in, whatever door or service, they will find their way to us, and we will support them and send them wherever they need to be. The day hospital is an integral hub for us as well. So that would be where we would have focused a lot of our attention on getting a clinic that was designed to be there for patients when things became difficult. So non-cognitive symptoms, issues with medication. So we have that rapid access, which has become absolutely integral to supporting patients and families. We also have the Dementia Advisor, Jean and Anya, who from the Alzheimer's Society have been amazing and have been linked into us for a number of years. So they sit in our service, in our clinic, once a month, and they will spend an hour with each family. So, absolutely integral to have that signposting piece. So you can move to the next. So talking in terms of post-diagnostic care, then I wanted to just, I suppose put a layer of what we do across that pathway, and just to show, I think there's so many things that we signpost patients to. There's a lot of things out there for families. And whenever I talk to GPs, they have a sense that there's nothing there. There's nothing there. They don't, sometimes don't know about the resource rooms. They don't feel that they're empowered to know where to send people. But there's a lot of things that we can do to, I suppose, bridge that gap between primary care and between what we do, and try and move as close as we can to becoming an integrated system, really. I won't obviously go into every piece of this, but one of the integral things that we've done is create a family care training resource. And we did that sort of triadic, so involving integrated care, staff from the memory clinic and primary care, and in association with the Alzheimer's Society initially we set this up, and so I think we've had about 60 families who are automatically referred to this course. And what you're really ensuring is that the family understand dementia, that they have a chance to think about how they're feeling, the grief that goes with it, the loss, but also the positive things. It's an opportunity to introduce them to think ahead, you know, to be thinking about that palliative piece in a kind of a supported way. But also, you know, to show them assistive technology, to talk about safety in the home. So, you know, it's been absolutely amazing. And Sean would actually come over for an hour and sit and open the floor, and we get a lot of questions which really show us what we should be doing. You know, what's the experience like for patients, what's good and what isn't good. So, you know, it's just, I suppose, using our pathway. Yes, we can have a menu of interventions, but you know, it has to be personalized. It has to be from what the patient wants and what they need. And I just think the complexity of dementia, every single, you know, family that comes through, they're going to need different things, and we can't describe that to them. We've got to listen and grow, I suppose, as we go. Citizens information, extremely important at the start, that we set people up well, that we, you know, inform them as to what they're entitled to. And we've had various groups, psychoeducation groups, and cognitive stimulation therapy, rehab. Again, you know, not appropriate for everybody, and we need to be very ethical around that piece. But again, you know, helplines, and just informing them of what's there at the moment, signposting them to the Understand Together website, you know, every place they can go in order to find support as they go through. So you can move forward into the next one if you like. Thank you. So I suppose I was trying to think what would be useful, and in you know, our service isn't the perfect way to do things, but we've changed and evolved over the last few years, and I think things that work, I just wanted to point out. I think one thing that we wanted to do was to remove some of the negativity from the diagnostic piece. And so our assessment, our initial assessment is, you know, a point of contact. They're linked to myself and Joshi, and we try to follow them through the whole journey. And within that piece is a narrative of loss. You know, you're asking what function is gone, what are the changes, and we like to kind of keep that in that box. So when the person comes back, following a rich MDT process, that the diagnostic session is really positive, and Sean spent a lot of time trying to create that. And so we have key staff that are skilled, very, very skilled reggers who are very familiar with dementia and all its guises. And just that empathy and the honesty is what families need and what patients need. And I think just to listen to their voices and open up the lines of communication, especially where there's an anosognosia, you really are dealing with a very tricky situation for a lot of families. And when Sean walks in and says, "I've heard all about you," because we've talked about them at MDT, you can see them visibly relaxed, because they don't have to sit and chronicle all the things that are wrong or all the things that have changed, which, you know, it just kind of nullifies the good. So what we would do, we developed a post-diagnostic clinic, Joshi and I. So at 7 weeks, we bring these patients and families back. We talk to them about what they understood, the side effects of any medication started, any questions, how are they coping, written information reinforced, and any referrals that we've made at the point of diagnosis, we just check where that's at. So just examples of what we would use. We would use men's sheds, we would use walking groups, you know, things, places and spaces where patients can't make mistakes or feel that they're lesser, you know. So walking requires nothing, it makes you feel great, you know. Going to see a picture, a painting, nobody's wrong, it's their own impression. So those things, I think, are very, very important. Music, volunteering, and I suppose just that whole piece of them feeling they can be part of trials and research. It's a very, very important piece, I think, to make them feel that they don't, you know, it's not all about loss, it's about change, and it's a way of being, but they are no lesser. So they're very important things, I think, that we need to be getting across. There's a narrative about dementia that doesn't necessarily fit with what we do and see. So you can move forward into the next piece, if you don't mind. I'm aware of the time. So I suppose final thoughts, you know, brain health shouldn't be an extra. It should be something that's embedded into everything we do. And the interventions that we put into place, hopefully they make really tangible, substantial changes in the way that people see the effect they can have on their own life, their own brain health, and to link it with heart health, you know, because I think patients are quite familiar with things you should do around your cholesterol, but you know, when you really try and enforce that message about brain health, it's amazing what people are doing. You know, we have people who are really reducing alcohol. We have patients who are, you know, addressing their mental health and exercising more and feeling better about themselves. I think the diagnosis, the delivery of it is only the first step. I mean, these families and patients, they know that about dementia. They know it so well by the time they come to us. And I think if we just leave them off and say, there you go, this is what you have, it's not enough. You know, they need us. They need us to be there, and we don't have a roadmap to give them. We don't have a disease-modifying drug, and I think it's all the more reason why we need to help them to feel supported. Building up capacity and support in the community is integral, and to allow them to live and their families well and to better mainstream their needs. And I suppose just that piece around, we don't have all the answers, you know, we really have to just go on that journey with them, and we need to listen. And we had a lady in clinic on Friday, and she described what it was like to feel that she had no control. You know, she's feeling anxious, and I mean, you know, together we move forward on that journey, and every time they come back, they'll have a different set of needs. Like, you can't describe, I think, you know, our own impression of what they need, and that it sits and it never changes, because it is an ever shifting sans situation with dementia. And I suppose lastly, just the simple things can be the most powerful. And I find this from families, they will say, you know, just point of contact person. It's just so important, and I think the Genio projects showed that as well. You know, when COVID hit, we rang everybody, and they, you know, they would say to us, "We knew you'd call," you know. So, and they're not greedy. Families don't ask for much. They just actually want truth. They want to be able to give the best care they can, and so we really do need to think about the simple things.
Okay, thank you so much, Cathy. That was an absolutely brilliant talk, and it was, even though we couldn't see you, we could hear you very clearly, and your PowerPoint was great. So thank you for you know, working through the technological difficulties, and thank you to you both for giving such a comprehensive picture to us. Before we wrap up, can I just ask you, in terms of COVID and the past 8 or 9 months and the next 6 months going forward, how your service has been impacted by this? I mean, that hugely rich post-diagnostic support, set of post-diagnostic supports you commented on there. What has been happening and what's likely to happen over the next 6 months to try and support people living with dementia and their families?
Yeah, no, I think you broke up there a little bit, Cathy, but I can just to say, I suppose we've tried to, during the early stages of COVID, needless to say, there was a big impact on the service, and we kind of had to, you know, really, like many other things, you know, stop seeing new patients in. As Cathy mentioned during her presentation, though, both herself and Joshie contacted all of the people who've been through the service during that to talk it through, in particular to talk about things like isolation, loneliness, stress has been particularly difficult for people who might, you know, who have behavioural and psychological symptoms, and for carers who are trying to support them. So I tried to give them, you know, some means of support. We were also able to take in people, so we were triaging, using that as a means of triaging, so that if there was people that we needed to see, either through a home visit or through a, you know, a visit to the hospital in a very secure way, we were going to do that, and we were going to manage that. From the point of view of the access to post-diagnostic service, so we are back up and running, and are kind of determined. I mean, and I jokingly say we're like the band on the Titanic now. We're going to keep playing until the ship sinks. So we've actually now just kind of decided to, you know, on the basis of what we saw through that first wave, we have to keep our services going. So from our point of view, we're really trying to, you know, do that. Or the exercise component, which Cathy was mentioning, so Xwell, which are one of our local partners, they're back up and running and doing their exercise intervention piece that we link in with them. They're doing it in the car park in the square. So lots of people have been creative and coming up with solutions about, you know, that awful phrase, living with COVID, and managing those kind of things. So what we've done is really linked with community partners. And I think Cathy and Joshie and the rest of the team, but in particular Cathy and Joshie, who do that post-diagnostic piece, what's really important about it is how you bring in those community partners, how there's lots of community partners who are able to support. And you just, all we need to do is, you know, if you like, provide and develop that ecosystem that people are able to plug into and out of. And actually, once you give that platform, there's lots of partners out there that are able to do it, such as the Alzheimer's Society and other groups who really are, you know, invaluable in supporting it as well.
Yeah, and of course the Dementia Advisor service is already linked in with you, so that's great. And the Alzheimer's Society, I know, is scaling that up as well. The band of the Titanic is, I have a comment here from somebody who said it's the dream team in Tallaght. So definitely not a band on the Titanic. I think so many comments coming in here, thanking you both for your talks and also the service that you provide. So, so yes, thank you very much for the talks today. Before we finish off, I'm just going to launch a little poll here, just if people just let us know what they thought of this session. That'd be great. It's help for us. And also our poster presentation, we're going to have poster presentations here at 5 o'clock. So everybody who has booked into the conference will have a link for this room and a link for the other room, and likewise for tomorrow. And we have another full program tomorrow. So thank you again to our speakers, and anybody out there also who has other comments or would like to make comments that we didn't get an opportunity to get to today. We're on Twitter and we have hashtag DementiaConf20. So do feel free to be a part of, I suppose, in one of our other sessions, we're also talking about changing the narrative around dementia and really that coming together. So thank you.